One more person. Okay, so welcome everyone to our September CPD session. Thank you very much for joining us, and thank you specifically to our three speakers for today. So this session is focused on Module 8 of the CATCH web program, and so we're talking about psychosocial wellbeing. And I do have just a couple of quick messages before we start the program. So one thing, I apologise to everyone for the mad spamming of your calendars last week, but I'm hoping that everyone has now received all updated calendar requests for the meetings going forward up until the end of next year. And just so you can see what's going to be going on in our program, who our exciting speakers are, and sort of whet your appetite for attending those sessions. And the second message I just wanted to share was just a little quick reminder from the Heart Foundation before we get started. So Vanessa sent out a reminder email to everyone today about the Heart Foundation Cardiac Rehabilitation Update Day, which is scheduled for the 17th. So RSVPs for that session are due this Friday. And please remember that we still have 2 travel scholarships available for anyone who was planning to attend the session in person. Please email me if you need any more information about the scholarships. So our first speaker is here. Hello, David. I will just quickly introduce our first speaker, and then we can hand over to him. Thank you very much for joining us today, David. So our first speaker today is Associate Professor David Colquhoun. So he's a clinical cardiologist in private practice in Queensland, and he's been involved in a wide range of practice and research in the fields of cardiology, nutrition, diabetes, obesity, and psychological aspects of heart disease. So David will be talking today about depression in cardiac rehab, and is open to lots of questions. So I'll hand over to you, David, however you want to organise your little session. I don't know if you wanted to present slides, or we'll have this as like a chatty session instead. Oh, you're still on mute.
Can you hear me now?
Yes, we can. Thanks.
Okay.
David.
Well, how about I'll have I'd say a few points, and then we can get into the question backwards and forwards. So, as a background, the Heart Foundation, I've been part of the Heart Foundation Special Working Group. We looked at psychosocial factors over a decade ago and came to the conclusion, looking at the literature, before the American Heart Association and the Europeans, that certain psychological factors are major independent predictors of first and recurrent heart attacks, as well as strokes. So we said that back then, and then about 5 years ago, we did the second part. Well, if depression's important, how do cardiologists, nurses, and other practitioners, what's an easy, quick way to do a screen? So yeah, we left it for a few years before we told anyone what to do. And so that's why we did a screening and treating for depression. Again, we beat the American Heart Association by at least 3 years. They didn't acknowledge that because, you know, they need to be number one. So the psychosocial risk factors, number one, best example of predictors is depression, of course, which occurs in up to 30% of our patients with coronary disease or at high risk of coronary disease, i.e. diabetics. And it's quite common after stroke. So depression, social isolation, but that's pretty hard to improve on that one. Then, of course, we have schizophrenia, which is far less common, but it's the major cause of death in schizophrenics after the early phase of suicide. And then PTSD, I was involved in our initiative here at Greenslopes, which is, if you like, a very troublesome one where people have had a life-threatening experience, such as being in the army, but far more cases of PTSD are actually from victims of rape, which of course is mainly women. That's often forgotten. Anxiety is often associated, but it's not nearly as powerful. And that's probably it for the psychosocial risk factors. They're common, and as Ian Hickey used to be head of Beyond Blue used to say, David, just being nice to people can improve depression. That's why so many different therapies seem to be as good as or better than placebo. But it's interesting, doing nothing, some people improve, but not very many. Doing something, even if you're not all that skilled, paying attention and paying interest can have an incredible therapeutic role. So depression, the screening tool, which is actually pretty easy to remember, even for a cardiologist. So the audience here today, sorry, it's who is the audience mainly? It's not doctors, is it?
No, so cardiac rehabilitation nurses predominantly, but some people from the Heart Foundation, some research people.
Okay, good. Yeah, that's what I thought. So really, doctors, and I gave a talk last night at our cardiology meeting on cholesterol, didn't talk about psychosocial risk factors. Cardiologists have moved into being very good at doing things such as ballooning, stenting, pacemakers, TAVIs, but moving away from talking to patients. So are general practitioners moving away because to survive the 5-minute consultation, was it 5 or 6 minutes is ideal. You can't do a lot in 5 to 6 minutes. So this is where cardiac rehabilitation is good. The screening that wasn't done in the hospital, that is forgotten, is the 2 questions, of course, the PHQ-2, which is on our website there. Download it, it's free. They're the first 2 questions. One, you've got to have one of them positive to make a diagnosis of major depressive disorder. And then, of course, there's the other 7 questions. They're the 9, which has been part and parcel of the criteria for diagnosing major depressive disorder for getting close to 20 years now. So the questions are the screening questions. So if you want to remember, go to the Heart Foundation website, and it's actually, the website is a little bit tricky now negotiating through, but it's free. You just download it. So screening is over the last month. Have you been bothered by feeling down, hopeless, or depressed? So it's a yes or no answer. If someone is saying, "Oh, I'm not sure," well, if you're not sure, we'll call that a yes. Over the last month, have you been bothered by lack of interest and pleasure in doing things? Again, yes or no. One of either of them has got about 90% sensitivity and specificity for major depressive disorder. It may only be mild, but you've got it. Now, there's a lot of patients say, yes, but it's because of, well, it's a bit like you've got a broken leg. Whether it's because someone tripped you or you had you got a broken leg. So a lot of people like to attribute why they feel rotten for all sorts of reasons. I say there may be very good reasons, but have you got this problem, yes or no? It's a bit like, have you got high cholesterol? Have you got diabetes? People attribute lots of things. It's whether you've got it or not. And as I say to patients, this is not rare. At least 1 in 3 people have angina like you had this, and it's a cause of being miserable. And it's the only risk factor or cause of coronary disease which you can feel. You can't feel diabetes, you can't feel blood pressure, you don't feel cholesterol, but you feel this. And this risk, treating this problem or risk factor, if you like, you actually can feel better, feel happier. Not that we're pursuing happiness per se, we'd like to take away some of the misery, So it's really simple. 2 questions. Honestly, it should roll off your tongue when instead of saying, "How are you?" And you often get, this is very unscientific, the vibes, right? The vibes. And I know many psychiatrists and many psychologists don't like to do the PHQ-2. I don't know why. They get the vibes and say whether they think someone's got depression. Very unscientific. It's very sort of new agey. I got the vibes, but when someone, the body habitus, and very frequently it masquerades when they see doctors and the nurses and whatever. "Oh, I'm just so tired." Now, if you're a good mechanical doctor and you've heard about snoring, you'll do a sleep apnea test. That's not necessarily the cause, not necessarily, it's rarely the cause of "I'm so tired." Sleep apnea, which is seen in many of our patients, right, but it doesn't causes daytime somnolence. So even the placebo effect of spending a few $1,000s on a mask, which is pretty noisy, that rarely actually leads to improvement in the fatigue, which is related to the depression. Depression can be associated with sleep disturbance, particularly if you've got PTSD, but sleep apnea masks are not a treatment for depression, above and beyond placebo. So treatment makes people feel better. That in its own right, as my friend Ian Hickey would say, there's nothing wrong with making people feel better if they don't live longer. Or if they live longer, that's a bonus. Making people feel, enjoy life. Life's not such a burden if we treat the depression. Now, what we know is with the newer trials of antidepressants, up to half of the benefit can be explained by the placebo effect. In some studies, a bit more than that. Maybe 25% is actually the drug or less. So just initiating a treatment, there's a strong placebo effect. Particularly, very interesting study using St. John's wort. It was used as a weapon against St. John's wort, I must admit, by the people who don't like anything that smells or just tastes of complementary medicine. That in itself is unscientific, but that doesn't matter if they're oxymoronic, but that's okay. Many of us are that way and slightly contradictory. We're humans. That if you believe in the treatment, this is the St. John's wort trial, you get a better response if you believe in a randomized trial that you're on the real thing. The mind is very powerful in being for good and evil, as we know around the world, of course. So if you believe in the treatment, which means you as the therapist give encouragement, you get much better response. That is ethical. That's the way it goes. It's sort of like adding placebo to the therapy. I did that in one letter, and a patient said, "What are you doing giving placebos to patients?" Oh, misinterpreted. English is tricky. It's not undermining the therapy of the treatment. You're adding to it by you as a therapeutic person. So what we know is this, and this was argued for a long time by some of my colleagues. You might be improving the depression, but you're not preventing heart attacks. Well, I'm relieving depression. That's pretty good. That's all psychiatrists do and psychologists, is that most of their work is relieving depression. There's nothing wrong with that. But we now know long-term follow-up of the Sad Heart trial, and I was involved in that. David Barton was involved at the only other two sites, Melbourne and in Brisbane, outside of North America, that was using Zoloft, which showed a small benefit at 6 months compared to placebo. Long-term follow-up of that and another trial, the Enrich trial. If we look at 10-year follow-up, resolution of depression, whether it was you were on placebo or on active, you had the same benefit of lower mortality at the 10-year mark. So it's interesting. It doesn't have to be a drug to lead to resolution. If it was resolved when you're on placebo because of the mind, you get the same benefit and decreased mortality. That is fantastic news. So improvement, like lowering cholesterol, it's lowering it that counts. It's getting rid of the depression that counts. So that's fantastic news, that if it resolves, it doesn't seem to matter how it resolves in a number of long-term trials. The other thing I just want to mention, and then I guess open for questions, in our Australian lipid trial, we measured, the lipid trial was 9,000 patients post-heart attack, randomized to pravastatin, which lowers LDL by only 1 millimole per litre. It was thought lowering cholesterol might, at that time in the 90s, might precipitate depression, and some people in the UK even said it might lead to suicides. It was a silly hypothesis, but it had a lot of currency amongst doctors and other people, because the brain's full of cholesterol. Misunderstanding. So what we did is measured a baseline, the SF36, I think it was, and there's a measurement of distress in that, right? We did a baseline in 1,000 individuals. That's a lot of people. 6 months, 1 year, 2 years, 3 years, 4 years. And we measured distress. And was it none, mild, moderate, or severe? And was it more than 3 times during that period when we measured it? So of the 9,000 patients in the trial, we had 1,000, huge number. What we saw is if you had moderate plus distress on more than 3 occasions out of the 6 or so we measured it, your mortality at the 10-year mark was 200% higher. So we all get a bit distressed occasionally, but persistent, moderate to severe, it's a powerful predictor of death. So, you know, that's accepted out in the lay public. If you're really distressed, it's bad for you. Yeah, that's true. That is true. So we demonstrated that, and it's interesting. It's published in the BMJ. There was an accompanying editorial to our paper. When I say our paper, I was one of the authors on the paper, the second author. But we presented the European Societies of Cardiology, and we were quite happy that we got officially was the best in session of the poster sessions on psychosocial factors and heart disease. It was, they didn't even give us a medal actually, but anyway, we all felt, Ray Stewart from New Zealand and we felt pretty happy that you know, it was accepted then, and BMJ we got an editorial. So I guess I might stop there. It's common. The treatment, it doesn't matter which treatment you use, as long as it works in the patient, it makes people feel better, and probably the data is less heart attacks and you live longer. So I might just pause there.
Okay. There was a lot in there. Now I have questions, but I'll open it up to the group first. So did anybody have any questions? Oh, Sherry? Oh, sorry, Kerry. I always mispronounce that. You're on mute.
Hello.
Yeah.
I work in cardiac rehab, and we have a lot of people that present, and they are on depression medications. They're chronic long-term depression, and quite often though they all say things like it's no different to what it normally is, their depression. Yes. So in that circumstance, they're on medications, and where do you go from with that? And the next question is, we quite often find that the fact that they join the group, participate in education, their depression will go by the end of the 7 weeks. They score a lot lower. And then once we do, say, the 6-month review, I notice that quite often it's returned again. So you know, there's lots of issues there in regard to, yes, you're saying medications, but there's more to it than that, I feel. And yeah, the management with a GP and things like that, where do you go? What do you do as a nurse? What's your next step?
Yeah, good. Yeah, you've raised a lot of points there. First up, we know, particularly depression and heart failure, there was a fantastic trial that compared exercise, because that's up to 60% of depression and heart failure. So it was exercise. Blue Menthol was the guy who's been involved in a lot of this stuff. So Johns Hopkins. So exercise was compared to exercise, and I think it was Zoloft, and then the alternative, just not doing any of the above. Exercise, regular exercise, it's a bit like taking tablets regularly, not taking one a month for your cholesterol, like regularly, was almost as effective as the drug by itself. Combination was slightly better. So often when you're in the rehab and you're coming along, both it's a social contact, which again can improve depression scores, and there's the exercise, because almost all rehab programs have an exercise component, right? So you've got 2 things there which improve depression, but if it stops, like stopping medication, it goes away. Medication, I mean, there's responders and non-responders. If we look at just Zoloft as one tablet, only about 20%, 10 to 20% get resolution. Another 20-30% have improvement, but a lot of people are resistant. So you have the original dose, double the dose, but you might need something else totally different. But depression can just come back again, of course, if you stop the therapy like blood pressure or cholesterol, look upon it like that. The other thing, there can be other triggers that help the depression, precipitate depression. So we know not everyone can see a psychiatrist because there's a worldwide shortage of them, and every year the age is going up. General practitioners to survive the 6-minute consultation, I think, is the ultimate. Psychologists, we have quite a few around, but it's often a combination of all of the above. Now, what is a new treatment, which is incredibly effective on MBS, it's MBS item number, but of November 1 will be a tiny bit of subsidy, is transcranial magnetic stimulation. It's just on the head. It's magnets, actually. It's been registered in the United States for about 10 years for refractory depression, but it doesn't have to be refractory. It's quite effective. But again, often people, they relapse after treatment and after going away, as you said, from finishing the program with you. So it really is something that needs to be checked in, like cholesterol every year. They need to have their PHQ-2 and 9 to assess what's going on, because it does relapse. So as a nurse, what do? I think walking per se, half an hour most days, is a bit of a threshold thing. And how hard? Moderate for you is the way to go. It doesn't matter whether it's walking or swimming. You don't have to go to the gym. Now, Mediterranean type diet, there is some evidence for that, for preventing the development of depression. In addition, the omega-3, there's been a number of trials. If you know the Black Dog Institute, the guy who started it was my old professor of psychiatry. He did a trial. Omega-3 can improve depression, but probably the doses, I did say to him, to Gordon Parker, the dose is a bit low. To know whether you've got an adequate dose, we now have available, Queensland First, the omega-3 index, to know whether you're having an adequate amount of the omega-3. You see why omega-3? Well, the brain, 60% of the brain is fat. Of that, 30% is DHA, which is fish oil, essential for life. So I think there's a few things there, but I've probably opened up more questions than I've answered, I think. It's a lifelong, well, I'll be new agey, a lifelong journey, keeping the moods balanced, let me say.
Definitely. Thank you.
Was there any other questions from the group? Oh, yeah, chat project, or whoever is in the room with you. Yeah.
Hi, David, it's Robin. Great to see you. Thank you for the great overview. That was really good. As you remember, I worked with Henry Crum on the chat project and made almost 2,100 calls to heart failure patients. And I speak often with the telehealth guys here, and we talk about the anonymity of treating patients by phone. Patients are a lot different when they're on the phone than when they see you face to face, and they feel a lot more comfortable in telling you all their secrets often. And I was quite overwhelmed with the heart failure patients that we were working with. And I took myself off to a CBT course. What small courses, and I'm sure the same sort of thing happens in the face-to-face in country, because country is, you're often the only port of call, or you may be a nurse and you're a safe port of call, and then there's a moment and a patient will just decide to open up all their blues in your consult. So what would you advise our team as far as small courses, mini training, online web, places to go to get some additional skills to deal with patients in that acute situation before referral?
Well, now you make me feel a bit uncomfortable out of my field of expertise. Being a city slicker, it's a bit easy for me, and I've got a few mates as psychiatrists. Yes. Well, I guess just simply asking the questions, the PHQ-2 and 2, and then going on to the 9. I must admit, some people I've got to be careful with, because, you know, the concept of depression just, you know, totally freaks them out, particularly males. So I just talk about your mood. Yeah, this is a mood thing. And, you know, we all go up and down, and when it's gets stuck down there, this just really makes you feel terrible, worn out, tired. We can explain a lot of what's troubling you. And look, you know, I can say, look, it's quite frequent now. But the question is what courses, etc. You know what? I can't rattle it off. I'll put that on notice like a good politician, and get back to you. I'm not sure whether the psychologists are running it. That actually would be a great idea for I'm on the board of the Heart Foundation. It's actually a great idea. Do you want to put an email to me? Because I'll take it to the board, because, you know, we're reassessing things that we need to do. And this is an area of need. We can't just keep delegating. You're seeing the patient. You need to do something now. And just to feel more comfortable that you're actually on the right track. Having said that before, that if you have no idea what you're doing, patients still get benefit because you're caring. I think that's really important. It's not the exact dose of the drug. It's not the exact combination. Remember, in some studies, 2/3 of the benefit is just the placebo effect of taking something that's meant to help you. So I guess I'll take it on notice, but yeah, send me an email and I'll take it up with the board, because I'm on the Heart Health Committee. And again, although we've got those papers in the past, we still tend to focus on, you know, education for blood pressure and all this sort of stuff. And there's so much of that around, it's pretty obvious. This is, I think it's actually more important, because if you like, the workforce, the expert workforce, there's waiting lists of 2 years and not taking any patients. In other words, the psychiatrists. And then you've got, not necessarily all the psychologists have had the extra training in depression, although you would think most would. But, and you're not stealing their business. That thing goes on. You are actually identifying and providing, if you like, the first line therapy, and maybe the only therapy. But thank you for that question.
That would be fantastic, David. If we'll send you an email and with our wish list for sort of classes that clinicians will benefit from. So if anyone has anything that they want to add to that email, feel free to email Robin or I, and we'll pass that on to David. Now, this is fascinating, and I have more questions, but we'll move on to our next speaker. Yeah. So thank you very much, David. That has been very interesting, and you undercut Lemlem's pharmacy section at the end. No, it's more than just placebo. The medication works.
I know. Yeah. But it's just so powerful, the mind. That's the point. Yeah. Okay.
Absolutely. Thank you very much, David. And we'll move on to Trudy. Trudy, are you ready for this?
I am so excited. If I can share my screen, that'll be even a better start. So anyone that knows me knows that I don't love presenting things. So bear with me while I work this all out.
We can see it.
You can see it. Can you see it properly? Yep. All right. Yes. Very good. So for people that don't know me, I have been around for a little while. I'm Trudy Baker, and I'm the cardiac nurse at Port Pirie, and I was a respiratory nurse as well, but I'm transitioning into diabetes a little bit because a lot of people I see have diabetes as well. So our Better Care community program in Port Pirie is probably similar to others, that we have strategies to avoid hospital admissions with people with chronic conditions, length of stay of clients in hospital, so we try and get people out sooner. We improve access to services from Aboriginal and Torres Strait Islanders, so that means that we associate with Te Pari a little bit, who's our local Aboriginal network. We try and get people back from Metro quicker. At the moment, that's the buzz, isn't it? So they don't want people in Adelaide hospitals while they're on standby for all these cases that may come in. Our chronic condition groups that we focus on are diabetes, cardiac and respiratory conditions. So that would probably be similar to a lot of areas. So with diabetes, we use some RIBS funding for flash glucose monitoring. At cardiac, we do clinic consults as well as cardiac rehab. With our respiratory conditions, we do sleep studies, our pulmonary rehab program, and just clinic consults that include spirometry. So our team in Port Pirie, we have Tennille, who does 0.8 full-time equivalent. She's the coordinator. We have Monica Jackson, who's on leave at the moment, and Jo Rivers, who do the respiratory component of 0.8. Myself, who's 0.5, and just to shout out that I'm really busy in that 0.5. And it's not just that I'm disorganised, I am slightly, but it's also very busy. Mel Castle and Bruce Campbell, they do our health and wellbeing, which I'll talk about a little bit more in a moment. They do 0.7. Mark Wright and Stella are diabetes educators, and I'm working 0.5 in that field as well at the moment. And then we are lucky enough to have a program assistant, Annika, who does all our running around behind the scenes. And that's our group. So there's Mel, Tennille, Monica, myself, Annika, Mark and Bruce. And that was a nice sunny day where we had a meeting outside so we could take our masks off. And Jo Rivers, she's just joined our program from Port Augusta. She only started last week, and she's been working in respiratory, and she's got a background in paediatrics. So we're actually really spoiled with the staff that we have and the qualities that they have. I was just going to talk a little bit about our health and wellbeing, because that seems quite unique to Port Pirie. I don't know that others have quite the same sort of setup. So our health and wellbeing clients we refer to our health and wellbeing are those that are having difficulty with other aspects of their life, which is often quite common. So Mel has a history or a background in social work, and Bruce has a background in OT, so that's really helpful as well. So it's about supporting people with their psychological and their physical health, you know, not to the point of needing psychologists, but just to support those changes. Bruce spends a lot of time helping with NDIS applications and negotiating that field, which is almost a full-time position in itself. We refer to NGOs and allied health, and we've also in Port Pirie are lucky enough to have a food hub, which is helpful for those people that can't afford or don't have good food security, so we're able to refer to them as well. And these guys help people with individual goals and action plans. So, you know, they can spend a lot more time with them than just our one-on face-to-face consult. So our program, our cardiac rehab program in Port Pirie, it's free. It's offered at GP Plus. We have free access to a gym, so that's really good. We have a physiotherapist allocated to the program. We actually do a start-stop program in Port Pirie. So that's because we tried a rolling program before, which is gold standard. It is recommended, a rolling program, but I'll show you the figures later, and it just didn't work here. We only have one session once a week for 2 hours. The first hour is information on the heart condition and risk factors, and the second hour is exercise in the gym. Once people complete that program, they're eligible for a phase 3 maintenance program, which goes for 6 months. It's once a week, 1 hour exercise session a week, and that's taken up probably by about 50% of people. Now, because I wanted to look intelligent, I've put on a graph here, and this took me longer than you'd want to know. But this is our referrals to cardiac rehab in Port Pirie. And I just wanted to point out 2020 with the COVID. So our referrals went up quite noticeably, and it was quite a bit busier for that 12 months. And our year to date at the moment is sort of trending that way as well. Although I have to say for the last month, I think our referrals have dropped because I don't feel as frantic. So that's a good thing. But it's just interesting because I know ICCNet had, you know, saw a rise in connected players and everything when COVID first started. So when we talk about heart disease and emotion and psychological aspects, I guess that plays into that as well. Our cardiac rehab attendance, so in 2018 was when we started our rolling program. So we only did that for 12 months because we wanted to fit in with everyone else. The people that commenced cardiac rehab, the numbers were down, and of those who completed, the numbers, who did not complete, sorry, the numbers were elevated. So that was sort of enough evidence for us to go back to our start-stop program. It just works for this region for whatever reason. And our referrals versus commencement. So in Port Pirie, I worked it out, it's around 42% of people who are referred for cardiac rehab actually commence cardiac rehab. So, I mean, the numbers aren't great, but I'd love to see them higher, promote everything else like phone program, web program, whatever we can do. But some people just won't take those offers up, but we try hard. All right, so that's it. I told you I'd be quick. Any comments or questions?
Fabulous. Thank you, Trudy. If you want to stop sharing your screen.
You didn't tell me. No, I know now. Yep, got it.
Fantastic. Were there any questions specifically for Trudy and her service?
Yep, Gemma in ICCNet.
Hi Trudy, it's Gemma from ICCNet from Catch. Lovely to put a face to the name. Just wondering, out of those referrals, and you had that beautiful graph, we love it, with the commencements, how many other patients would you get referrals for that you either don't feel meet your criteria for rehab, or and then you might send back to Catch, or you might just not progress with? Like, are there many of patients that would fall into that category?
So probably a few. So I get some inpatient referrals that I do try and forward to Catch. So I've got them on my system anyway, because for all that whinging about that database years ago, I love it now that I can see everyone.
Yeah.
But yeah, there are quite a few, like particularly the heart failures that I don't feel that confident with in gym, who are still tacky and that sort of thing. I try and promote back to phone program. And, and then I'll go back and check, and they go, oh, I tried to contact. So, they've basically said, yes, they'll do the phone program to keep me happy.
Yeah.
And they're not engaged, unfortunately. But most of my referrals come through Catch, and most that I get, I try and forward to Catch. So I've got them there, even if they don't start cardiac rehab.
Yeah, okay, great. And with heart failure, and I suppose the other one that's a bit sometimes, some facilities can cater for is the AF. How do you go meeting the needs of all those different groups of patients?
Yeah, so they're all in the one group. Unfortunately, and I've even had people with partners who have identified 2 risk factors that I've enrolled in cardiac rehab just to get those, to capture those people as well. So our numbers, fortunately, we can have up to 10 people, and we don't often hit that. So so unfortunately they're all in the one group, but just with the physical activity, and the information's very general.
Yeah.
So it's all about heart disease. Yeah.
Yeah. Great.
David,
thank you.
did you have a question?
Yeah, I've got a question. Is that right? The snapshot a few years ago, 10 years ago, noted that 1 year after the acute coronary syndrome, the LDL was 2.4. That was when we had the target was less than 1.8. The target now is less than 1.4. I'm just wondering, you expect attendees to be slightly better. Do we have any data on what the on-treatment LDL level is? And did you do the PHQ on the patients?
So that's actually meant to be put in the Catch database, but I'll put my hand up and say I'm not putting the LDL levels in, and I know I should be, but it's a lot of work to find those levels. So apologies, I don't, but other services may fulfil that requirement.
I know it's a lot of work, but for every 1 millimole reduction of LDL, 25% less heart attacks, 20% less strokes, 10% lower mortality. And let me just say, recent data from the Sunshine Coast, it's got worse over the last decade. And some cardiologists say it's a GP's business. So it's quite important for the patient's survival and for the mind, of course, the PHQ-2, which doesn't cost anything.
So we do the PHQ-2 and the PHQ-9. And yeah, so the LDL levels, so in the My Heart, My Life book, I do say to them, get your GP to print out those levels. I go through the HDL, the LDL, the they use there. So, and I guess we're sort of about self-management. So, you know, it is about these people looking after their health and initiating, following up what those results are. But I understand what you're saying. And just to go forth with that, it was interesting what you were saying about cholesterol, because I did read something in the last 12 months or so about the serotonin and reduction of cholesterol, or more particularly LDL cholesterol. So I found that a little bit interesting that, you know, 20 years ago they were looking into that as well. So
yeah, well, serotonin's been up and about and around for quite a while, because I mean, that's how many of the antidepressants work. But LDL, it's fascinating. We get continuing benefit down to even less than 0.5, and plaque, you get significant regression when it's 1.8, the LDL, and even more when it's 0.8. So the only reason I say yes, self-management, the doctors are not adhering, and that's where you have not adhering to the guidelines. And just putting on my prevention hat from the Cardiac Society and the Heart Foundation, everyone's living it up to everybody else, and it's actually proven to improve survival, all sorts of stuff. So I just, well, when patients come to see me in my rooms, you know, usually we just ring up the Sullivan Nicolaides or the QML and just get them to download it, and they'll do it pretty quickly. So I just think that would be enhance things, because then you can give guidelines back to the GP, because the cardiologist usually, if they can't balloon and stent, they're not that interested, right? And the GP just saying what the current guidelines are, that would help the GPs, because they don't have time to look things up.
I agree. Thank you. I'll take that on board. And with that, yeah, it's just chasing up those results. We have lots of private clinics here, so we have to ring private doctors' clinics to get those results. If they all went to SA pathology, make my job easier. But yeah, there is capacity to do that. Thank you.
Yes.
Okay.
Very good advice. Thank you, David. Thank you very much, Trudy. And now you are off the hook. You're done. And I will pass on to Lemlem, who is going to just close out the session. Once again, Lemlem, I've sucked up all your time. So I'll leave you to, we may, if you hang around if you can, but if not, it is on the recording.
Thank you, Steph. So I'm going to share my screen. Can you see it? You can? Yep.
Yep, all good. Oh, no, what I see is an email screen.
Ah, okay.
Do you want me to share it? I've got it.
Yeah, we could. Thank you. But I already had it here.
Oh, so if, yeah, you just have to pick a different screen.
What about now?
Yep, that's it.
All right, so it will be continuation of the antidepressant medications. And we're going to see today which one are safe to be prescribed or effective for cardiac patients. So as it has been said, like medications may not be as much as effective as the psychological or motivational, the mind thinking part, but we'll go through it what depression is and how common it is and what are the possible medications for depression. So as you all know, depression is a common mental disorder that affects all ages, and it is an independent risk factor for cardiac patients and other chronic disease patients. As it has been said, it can either cause cardiac problems or other chronic conditions, or chronic conditions like cardiac illness can also cause depression. So it is really common, like 264 million people are affected by depression worldwide. And out of these, around 800,000 commit suicide on a yearly basis, which is a big and worrying number. So in Australia, 1 in 10 people have depression, which is 10.4% of the population, which is not small. And according to WHO, depending on the number and severity of symptoms, depression can be classified as mild, moderate, and severe, like it has been described by David. And the symptoms, like when it's mild, you will see some difficulty in continuing their ordinary work or less engaged socially. And when moderate, it will continue to be difficult to do ordinary work. And when it's severe, it's almost impossible to do any activity, which could be social, ordinary, or domestic activities. Or some of them can do it with a little or limited extent. So how common is it in cardiac patients? I was looking at some systematic review, and I found that heart failure patients with depression, they were around 42% worldwide. And when the severity of heart failure increased, depression level also increased, or depression prevalence increased like up to 55%. And in Australia, from the Heart Foundation, I found that coronary heart disease patients with major depressive disorder, they were around 15%, which was done years ago. And when we see all types of depression, those patients with cardiac coronary heart disease, they will have around more than 40% of them will have depression. So what is the problem? When depression is an independent risk factor, it will increase progression of heart disease and other chronic conditions. It will cause major cardiac events, which will increase like before, or also cause disabilities, increase healthcare expenditure, cause increased mortality, and reduce quality of life of patients. So when we see the possible mechanism of linking depression with cardiac disease patients, we can see it in two ways. The one way is like depressive patients with cardiac problem, they will have impaired health promoting behavior, which means they will not eat healthy food, they will have less physical activity, they will be prone or will not be able to stop smoking, and they will adhere less to medication, and which will lead to poor cardiac rehab attendance and completion. And the other way to see it is it also causes adverse physiological effects, which can cause lots of problems, like it will, with elevated platelet activation due to the serotonin level, increased inflammation, the hypothalamus pituitary adrenal axis will be less functional, elevated catecholamine level, endothelial dysfunction, and low brain-derived neurotrophic factors. So all this will also fit to each other. When these physiological changes come, the behavior thing will also come and cause the correlation of both, and it will cause adverse cardiac outcomes. So when we go to treatment, which already David took everything and said, oh, medications may not work as they should, which is correct. So I have tried to compile some possible treatments, not only medication, but CBT, and it has been shown that CBT is effective in coronary artery disease patients with less cardiac benefit evidence, but it has shown significant improvement in patients' treatment with PHQ-2 and 9 levels. And the other and more effective way of treating the depressive patients with cardiac problem is like the collaborative care model, which includes everything the patient needs. So it will be including the medications, but also the other physiotherapy or exercise, education, or the CBT treatment. So it has shown significant decrease in the PHQ-9 score after a year, and all the healthcare professionals will be involved in different ways depending on the patient's need, and that will be personalized treatment and really effective for the outcome. And exercise, like it has been said, it has been shown to be more effective in the early stage because they have the motivation and all the ability to do, but later on when it's severe, it's not because it will not work, but maybe the patient will not be able to do that. And it has shown more efficacy in the early stages. And education is also really helpful. And when we come to medications, some of them are recommended based on studies to be prescribed for depression with cardiac patients. And like I said, the best treatment for depression in cardiac patients is to combine all multimodal, personalized, flexible depression care management approaches, which are found to be effective in these patients. So when you come to medications, the selective serotonin reuptake inhibitors appear to be safe and effective, especially in coronary artery disease patients, with some efficacy for cardiac patients, also with cardiac benefits, while its efficacy has been less evident in heart failure patients. So the studies have shown that except for paroxetine, other selective serotonin reuptake inhibitors has failed to show efficacy or significant difference from placebo in heart failure patients. So when we see the mechanism of action, how these medications work, as you can see from the diagram, their name also indicates they are selective serotonin reuptake inhibitors. So what do is they will inhibit the uptake of serotonin from the synaptic cleft into the presynaptic membrane. So they will bind to the 5-HT receptor transporters, and they will increase the availability of serotonin on the synaptic cleft, which will be able to attach or bind with the 5-HT receptors and give its all effect, which is needed for the depression treatment. And as you all know, medications come with their all adverse effects, and these medications, in addition to have the delayed pharmacological efficacy, which will depend based on the patient, how fast it is, and adverse effects also vary from one patient to another, but it will take some time to adjust which medication works for which patient or how the adverse effects could be addressed in the patient based on the individual adverse effects. So they can cause agitation, feeling sick, like being sick or nausea, indigestion, diarrhea, or constipation, loss of appetite, and blurred vision, dry mouth, excessive sweating, the list goes on, and it causes low sex drive, erectile dysfunction, which is most of related with the mechanism of action of the drugs and the level of serotonin. And that's all. And it's good that I finished in time today. And thank you.
Thank you very much, Lemlem. If you want to unshare your screen. Now, did anyone have any questions? I have one, but I shall open it to the group. David?
Don't ask me hard questions.
You just have to unmute, David.
Yeah.
Yeah, sorry. That was good, and it dovetailed in nicely, I think, with what I said. In terms of the serotonin uptake inhibitors, I had dinner with David Barton, who was the other Sad Heart investigator. That serotonin side effects that you mentioned, that tends to be in the beginning because of the serotonin, the uptake and inhibition. So a certain proportion get it, but it's better if you go slow and build up and you don't get the serotonin type syndrome. It's interesting, heart failure. That's a trial where Zoloft or sertraline didn't work. I think part of the problem in heart failure and lack of response is the depression's on the basis often of vascular disease. So you've got anatomical changes and it just doesn't respond to anything. I think that's part of the problem. Also, the low iron. These people often have low iron in heart failure, 30%. And if you fix the iron up, which you often need a ferrojet infusion, the low mood can improve as well as the shortness of breath. Or if they've had strokes, nothing responds, mini strokes. But, I think that was a great overview. Thank you very much.
Thank you. That's addition to my presentation. Thank you.
Is there any other questions from the group? I might just ask one quick one. Does this mean people stop taking their medication for depression because of the side effects? Because that's a big list of very uncomfortable side effects.
Yeah.
I know it looks like that, but it may not occur any of it in any patient. So it depends how the patient reacts to it and how it responds. So there will be a way to reduce, even if they occur, there will be a way to manage it by discussing with the GP or the healthcare, and they can change to another medication or reduce the dose depending on how it should. Yeah, it may not occur for all patients.
Can I ask something else? You didn't mention St. John's wort, which all our patients like to talk about.
Yeah, the interaction.
Oh, no, that's grossly exaggerated by the anti-science lobby who call themselves doctors, right? The evidence of St. John's wort interfering with anything is incredibly slim. But the same doctors will use amiodarone, which is incredibly toxic and miserable, increases mortality. So St. John's wort has been, it's a bit like the bashing of AstraZeneca. It's totally unfounded, right? And that's geopolitics. So St. John's wort, head-to-head clash, not necessarily in cardiac patients, has about a third of the side effect profile with the similar efficacy as SSRIs, just by the way. So I wouldn't wipe them away. Now, that is above and beyond placebo. But the omega-3 fatty acids, remember, depressed patients have much lower omega-3 index, and that correlates with unstable angina as well. So there's a lot of research to do. You can be involved.
Absolutely. What I focused on is the medication pharmacotherapy side of it. But what you mentioned are like the alternative medications or the complementary medicine, we call. So I just chose to focus on the drug-wise or medication-wise. But you are absolutely right that there are lots of ways like omega-3 and estrogens that you said, but also additional, the interaction side of it is also there, but it depends on the genetic makeups of the patient and the drug they choose to take. So, yeah.
Sounds like an interesting topic for a future session. All right, so once again, we have totally blown over time, but shall we draw it to a close there? Any other burning questions that must be asked?
Burning.
Can I just add from ICCNet, we would just like to thank Professor Trudy for her amazing presentation today. And we did love her graphs in particular. And could she please email me about her PhD?
Thank you as always for your support.
Okay, so thank you very much to all of our speakers. It has been a very interesting session, and we will meet you guys back here again next month. Thanks, guys.
Bye.